Good morning, all of you. Myself, Dr. Gaurang, Reader, Department of Oral and Maxillofacial Surgery. Today, we are discussing a topic: Ludwig angina. What is the meaning of angina? Angina means choking. Okay, and these are my content: regional anatomy, Ludwig angina, etiology, clinical features, investigations, management, and conclusion. These are the regional anatomy of head and neck, where the parotid gland, buccinator muscle, mucosal membrane, duct of salivary glands, all are present. Lower mandible, we have a muscles also, and tooth present, and Ludwig angina comprises of the three spaces: submental space. First is submental, boundaries, roof, myloid muscle, inferior, deep cervical fascia, platysma, superficial fascia, and skin, laterally anterior belly of digestic, and posteriorly submandibular space. What are the content of the submandibular space? Lymph node, anterior jugular vein, and what is the source of etiology? Infected mandibular incisors, anterior extension of the submandibular spaces, sublingual space. Second is a sublingual space. It has four boundaries: superiorly, mucosa of the floor; inferiorly, myloid muscle; posteriorly, body of hyoid bone; anteriorly and laterally, inner aspect of the mandibular body; medially, genoid, styloglossus, genoglossus. And etiology of infection: infected mandibular, premolar, and first molar. Then submandibular space infection. This is a third space which comprises and make it Ludwig angina a single unit, single disease by these three spaces: boundary superiorly, myloid muscle; inferior border of mandible; inferiorly, anterior and posterior belly of digestic; laterally, deep cervical fascia, platysma, superficial fascia, and the skin; medially, hypoglossal, styloglossal, mylohyoid muscle; posteriorly, hyoid bone, and submental space anteriorly. Etiology of the infection is infected mandibular second and third molar, and from submental and sublingual spaces. Now, what is Ludwig angina? The acute spreading, potential life-threatening form of cellulitis in the region of the submandibular gland, causing severe swelling and tenderness with fever, pain, difficulty in opening the mouth, and in swelling. There are some danger. Swelling might extend to the voice box, larynx, and cause apraxia. The usual source of infection in grossly neglected teeth, and antibiotics are necessary. Etiology: these are due to the dental caries, recent dental treatment, poor oral hygiene accounts 80 to 90% of the cases. Oral soft tissue laceration, puncture wound of the floor of the mouth, secondary infection of oral malignancy, and submandibular cellulitis. Systemic complications such as AIDS, GMR, nephritis, diabetes, anemia, transplant recipient, chemotherapy, etc. Clinical feature: bilateral wood-like swelling in the submandibular, sublingual, and submental space. Rapid onset. Skin is tense and tend to pit and blanch on the pressure. Rapidly spreading edema and double chin appearance. Elevate and protrusion of the tongue, drooling of the saliva. Elevation of the tongue is associated with dysphagia, olophagia, dynia, and cyanosis. Patient may exhibit muffled voice due to edema of vocal apparatus, hot potato voice. Septicemia, high-grade fever, body ache, and increase in the leukocyte counts. Infection can be spread to involve the masseter space and parapharyngeal space, which are the posterior to these all three spaces. Clinical feature you can appreciate in dyspnea is in supine position, laryngeal edema. The thumb sign on epiglottis is indicating laryngeal edema. There is, you can see there is edema on the larynx, which compromise the airway. What are the investigations? Panoramic X-ray to identify possible odontogenic sources, cervical profile and posterior anterior radiograph to observe the volume increase in the soft tissue and any deviation of the trachea, and ultrasound to recommend cellulitis, differentiate between the cellulitis and the abscess and adenopathy of head and neck space infection. CT scan is also a useful and most widely used. Ultrasound is very sensitive in detecting fluid collection in body everywhere. If fluid is collected, then we use ultrasound. In head and neck also we use ultrasound. Quick, widely available, relatively inexpensive, painless procedure involve no radiation and effective diagnostic tool to confirm the abscess formation in the superior facial space and is highly predictable in detecting the stage of infection. Differential diagnosis: lymphadenosis, peritonsiller abscesses, cellulitis, angioneurotic edema, salivary gland abscess, sublingual hematoma. Treatment goal: sufficient airway management. First is sufficient airway management has to be secure. Early and aggressive antibiotics should be given. Incision IND who fail medical management and from localized abscess. Adequate nutrition and hydration support. Airway management, then medical management, and then the surgical management. Airway tracheostomy, cricothyroidotomy, blind nasal intubation, that is called BNI, and fiber optic nasotracheal intubation. Tracheostomy. Tracheostomy using local anesthesia was considered as a gold standard in the past, but risk of a spread of infection to the mediastinum, aspiration of pus, rupture of the immorated arteries, and spread of infection to the thorax, airway loss and tracheal stenosis. Blind nasal intubation is questionable because of infrequent success on a first pass and increased trauma with repeated attempts, and might necessitate emergency cricothyroidotomy. Sometimes preferred instead of tracheostomy. Perceived low risk of spread, infection to mediastinosis. Fiber optic intubation is sophisticated and less invasive method of securing airway in patient with deep neck infection. So these are the procedure where we puncture the cricoid. First we feel the cricoid cartilage, and then we either give vertical incision or horizontal incision. Then we dissect layer by layer and reach the trachea, and then we aspirate. Then we put a syringe with saline or LA, and we see the air bubble entry is present. Then it's confirmed that we are in a trachea. Then we put tracheal dilator and remove that trachea, and then intubation has to be done. Medical management: intravenous access, fluid resuscitation, and administration of IV antibiotic. Antibiotic therapy should be administered empirically and drilled to culture the sensitivity of the result. Antibiotic therapy should be administered empirically and should be given. Other penicillin with beta-lactamase inhibitor, second, third, fourth generation cephalosporin and metronidazole is also preferred. IND as a surgical management, bilateral submandibular incision as well as midline submental incision. Incision approximately 3 to 4 centimeter below the angle of the mandible and below the inferior extent of swelling roughly parallel to the inferior border of the mandible. Principle given by the Tropazium and Goldberg. Incision in healthy skin and mucosa when possible, not at the site of maximum fracture, because these wounds tend to heal with a unsightly scar. Scar will happen. Place the incision in a natural scale fold. Place the incision in a dependent position. Dissect blindly. Place a drain. Remove drain when drain become minimal. And these are the few pictures. Tracheostomy and IND have been performed. And what is the conclusion? Ludwig angina is a life-threatening infection. Early diagnosis and immediate treatment is the key for successful management. Antibiotic therapy should be administered empirically and tailored to culture sensitivity. Prompt and early surgical intervention is required to prevent a high control over the patient health. Thank you.